During the High Middle Ages, human civilization reached a peak of interconnectedness not seen since the Roman Empire. A massive overland trade network, secured by the Mongol Empire, allowed silk, gold, and spices to travel thousands of miles across the Asian steppes and directly into the bustling merchant hubs of Europe. But the exact infrastructure built to share that wealth also transported an ancient biological agent. Hidden in the cargo holds of merchant galleys, a bacterium called Yersinia Pestis hitched a ride inside fleas on the backs of black rats, leaping from animal to human in the tightly packed Mediterranean ports. 6 centuries later, another sprawling logistics network fueled a different outbreak. The mass mobilization of the First World War crammed millions of soldiers into trenches, troopships, and trains, creating an incredibly efficient delivery system for the H1N1 influenza virus to cross oceans in a matter of weeks. By 2020, our travel architecture had scaled dramatically. The globalized economy relied on tens of thousands of commercial flights crisscrossing the globe daily, allowing the SARS-CoV-2 virus to leap from a single city to nearly every major country on Earth in under a month. What took the Bubonic Plague 4 years to cross Europe on foot and by sail, took the 1918 flu months by steamship and rail, and took COVID-19 less than 24 hours by air. As societies grow richer and more connected, the very systems built to share that prosperity become the exact highways used by pathogens to dismantle it. When the plague struck a medieval city, the physical toll was swift and gruesome. Victims developed sudden fevers, followed by dark, agonizing swellings in their lymph nodes, the buboes. The best medical minds of the 1300s operated entirely without germ theory and had absolutely no way to explain or treat the condition. The bacteria even became a weapon. During the 1346 siege of the Genoese trading colony of Kaffa, the attacking Mongol army found their own ranks decimated by the disease. In a desperate tactical move, they loaded their infected dead onto trebuchets and launched the bodies over the city walls, purposefully seeding the infection. This chart shows a seasonal influenza mortality curve. It forms a U-shape, indicating highest risk for the very young and old. But the 1918 virus deviated sharply, forming a W-shape that spiked drastically in the 20 to 40 age bracket. It triggered a biological mechanism known as a cytokine storm, a massive, unregulated overreaction of the body's own immune system. Because healthy young adults had the strongest immune systems, their bodies fought the virus so violently that their lungs filled with fluid, drowning them. This demographic targeting crippled the global workforce and broke the medical infrastructure. Thousands of patients flooded emergency wards, filling rows of cots in gymnasiums and armories. Medical staff worked to the point of collapse, trying to treat aggressive secondary bacterial pneumonias decades before the invention of penicillin. A century later, SARS-CoV-2 presented a different biological challenge. Because it could spread efficiently from people showing absolutely no symptoms, it bypassed early containment screens entirely. By the time the most vulnerable patients, the elderly and immunocompromised, required hospitalization, the sheer volume of cases strained the world's most advanced intensive care units to their absolute breaking point. Whether facing a medieval municipality or a highly advanced modern hospital network, a novel pathogen replicates and spreads far faster than any physical institution can adapt to contain it. As death tolls mount, the invisible threat begins to fracture social order. In the 14th century, the terror of contagion caused parents to abandon their sick children. Others turned to extreme religious penance, joining roaming bands of flagellants who whipped themselves in public squares to appease a wrathful god, while violent mobs scapegoated minority groups. By 1918, society was already organized for total war, and the response to the flu took on a rigid, militarized tone. Entire cities mandated masks and banned large gatherings, forcing tightly packed groups of citizens into strict compliance just to keep basic urban services functioning. For the doctors and nurses on the front lines, the psychological burden was immense. They watched helplessly as young, healthy patients turned blue from oxygen deprivation and died within hours of admission, leaving the medical workers wrestling with a profound sense of futility. In 2020, the attempt to starve the virus of hosts led to a different kind of extreme behavior: global lockdowns. Billions of people retreated indoors, relying entirely on digital screens for human connection, while the busiest metropolitan centers on the planet fell entirely silent. Our protective gear and medical uniforms change, but the human response to an unseen killer, marked by deep fear, social isolation, and a desperate search for control, repeats exactly. By the time the Black Death began to recede in 1351, it had simply run out of accessible hosts. Current estimates suggest that up to half of the population of Europe perished in fewer than 5 years. The millions of empty fields and silent workshops created an immediate, severe labor shortage. Peasants, who had been bound to their lord's land for generations, suddenly held immense bargaining power. They demanded higher wages and better conditions, permanently cracking the rigid economic structure of serfdom. Culturally, the trauma left a deep scar. Art across the continent became obsessed with mortality, popularizing the danse macabre. These murals were a stark reminder that disease led kings, bishops, and laborers into the exact same grave. The 1918 flu also burned itself out naturally, though only after claiming up to 100 million lives worldwide. It faded quietly into history, overshadowed by the end of the war, but the immense devastation prompted nations to establish centralized health ministries and the first international disease tracking systems. COVID-19 ended differently. Rather than waiting for the virus to exhaust its fuel, scientists sequenced the pathogen and deployed highly effective mRNA vaccines globally in a fraction of the time it took to develop previous immunizations. Yet, even with that medical victory, the societal impact was massive. The crisis reorganized office culture around remote work, forced a total restructuring of fragile global supply chains, and exposed stark economic gaps between those who could shelter in place and those who had to work in public. Our medical technology will continue to advance, but the biology of disease will always test the limits of our connectivity. These massive outbreaks strip away the illusions of invulnerability, forcing the survivors to adapt, rebuild, and organize a slightly different world from the ashes of the old one.